We had a paper that we recently published looking at the use of palbociclib after progression, so in later lines of therapy. So the real issue with these agents are we have very good data in the first line, very good data in the second line. We have a little bit of data from abemaciclib in later lines of therapy, so we decided to look kind of in a, not really a clinical trials fashion, but an analysis of data that we obtained during an expanded access program for the drug. So when the drug was approved in 2015, there's a lot of areas that wasn't approved and insurance didn't approve of it yet. So we had about a year or so where Pfizer was providing the drug on an expanded access program. A lot of the women on that expanded access program had far advanced disease. The median number of regimens I think were 3 or 4, or if not more, for the metastatic setting. And what we did in the trial is that we gave them palbociclib with letrozole in general. It wasn't really as a single agent. And we saw responses. The response rate probably was in the 4 to 5 month range. Or not the response rate, the progression-free survival was 4 to 5 month range. I think the tolerability was fine. There was no real safety signal. So we just reported on that. And I think that it's interesting because we're now trying to figure out whether we should be retreating women with CDK4/6 inhibitors. I mean, I think that we had an abstract at this year's meeting, our group, combined with Atidya Bharti at Mass General and Joyce O'Shaughnessy's group at Baylor, UT Southwestern. And we actually put together, or it's Dallas UT Southwestern is Dr. O'Shaughnessy, but our groups put together some retrospective analysis of the use of abemaciclib after palbociclib treatment. And the trial that we presented was just palbociclib with no prior CDK4, but we now have abemaciclib after CDK4 treatment. And we actually again saw progression-free survival at 6 months, reasonable toxicity. So clearly, there will be a subset of patients that do respond to retreatment with CDK4/6 inhibitors. We just need to figure out and identify who they are. Well, so the question is, how do we identify those patients? We don't know. There's a lot of molecular biology trying to figure that out. I think that there was some really interesting data at this year's ASCO on DNA sequencing that was presented in a special clinical science session to try to figure out whether there are particular gene mutations that predict for resistance, like RB loss or something like that, that people are very interested in looking at.